surgical treatment of juvenile patients with Moyamoya disease based on the clinical use of hemodynamic measurements. It's Dr. Nariai from Tokyo to present that. Thanks for being here.
Thank you.
Dr. Scott, I will be the discussant for this paper.
Yeah, thank you. No commercial interest to be disclosed. Patients with Moyamoya disease commonly have steno-occlusive lesion in the internal carotid system, but the degree of hemodynamic impairment is variable, depending on the severity of IC lesion itself and the collateral blood supply from posterior cerebral artery and the external carotid system. Benefit of surgical revascularization for each patient should depend on the degree of hemodynamic impairment. In recent 10 years, we have been applying DSC MRI perfusion-weighted imaging or for selected patient PET to determine the surgical indication of juvenile patient with Moyamoya disease. We analyzed such strategy changed the treatment feature of juvenile Moyamoya disease by comparing these patients' trend and the former ones who were treated based on angiographic finding. This is the background of our former studies. Hemodynamic status of Moyamoya disease is variable, and we can detect it by using PET. And also, the degree of revascularization from indirect bypass surgery also depend on the preoperative PET factors, especially on the area of increased OEF and elevated CVV have very wide area of brain area is diffused from the implanted external carotid system. But the measurement of hemodynamics using PET is difficult for children. So we performed the comparative studies with PET and more easier technique, such DSA MRI. And we found that the elevated OEF can be detected by the area with prolonged mean transit time measured by the DSC MRI. So the elevated area with elevated OEF can be detected by the prolonged mean transit time than control region by high sensitivity and specificity. And when we analyzed the post-operative revascularization from indirect bypass surgery, the area with highly prolonged mean transit time is benefited very much. So, depending on such a former studies, we are now using DSC MRI for all juvenile patients. And this is treatment cases of our department, and we analyzed these 276 patients. And 165 of them were treated from 1997 to 2000, mainly by the information of angiography and symptom. But the other 10 years, 111 patients were treated by CBF analysis and symptom. Surgical technique, all of them were treated by indirect bypass surgery technique. For the anterior circulation, we have been using EDAS that was developed by Yoshiharu Matsushima from our institute. And recently, we are using encephaloperiostocin angiosis for the posterior circulation area, like occipital lobe or posterior temporal lobe. So this is a result of treatment. In all years, surgical morbidity, perioperative infection was as low as 4%, and no surgical mortality was recorded in all years. The change of the trend is maybe in recent 10 years, this person who were conservatively followed up increased. This was determined by the DSC MRI. This is a patient of 11 years who was found to have a headache and found to have Moyamoya disease, but the CBF is not bad, and he was followed up for years. Recently, he had no symptom. And another change was noted in the increase of unilateral surgery in initial operation. We patients were followed up, and for some patients, additional surgery was performed on the other side, but the rate of additional surgery also decreased a little bit. This is an example of a patient. This patient have bilateral lesions, so this is Moyamoya disease, but in initial stage, only the left side hemisphere have the impaired circulation. We operated this patient. But 3 months later, CBF on right side get worse, and this was, side was showed increase. And just in 3 months, vascular lesion developed. So we analyzed concerning on the unilateral operation and additional surgery to it. And person who needed additional operation and who didn't need additional operation, the initial age at the operation age was slightly younger for the patient who needed additional operation, but there's no statistical difference, and in both groups, the age range was 3 to 18 years. And the interval between two operations was around 10 months or 11 months in both age. But in this group, only one patient received the operation 44 months later, but the other other 12 patients received the operation within 2 years. So most patients received additional operation to the contralateral side within 2 years. Another change was the increase of operation to the posterior part of the brain as initial surgery. This is an example of a patient. 10 years ago presented transient blindness, and he had a severe posterior cerebral artery lesion. And CBF measurement revealed that mainly the posterior part of the brain have worse hemodynamic impairment. So in this patient, only posterior part was operated bilaterally using encephalodial periosteoangiosis. This is a indirect surgery using periosteum. And very good revascularization was induced by this surgery. And this patient had a bilateral lesion, but only in the right side. He had a severe IC lesion and together with severe PCA lesion. And his cerebral CBF measurement indicate that the posterior circulation have much worse hemodynamic condition. So craniotomy was extended to the posterior part of temporal and the posterior parietal area, and the EDS and EDPS was applied in one craniotomy. Very good revascularization was induced from STA, meningeal artery, and occipital artery. So hemodynamic condition ameliorated. In this follow-up period, the other side also gets worsened, but the CBF doesn't change, so we're following up this patient. Finally, we analyzed the additional surgery to the posterior part of the brain. Such as surgery are now increasing in these 10 years. This is an example of the juvenile patient. In this patient, at the age of 7, she received a bilateral surgery, but just one eye and once symptom ameliorated. But 1 year later, her TIA recurred, and at that time, PCA was not visualized, and the posterior part of the brain have hemodynamic deficiency. So we applied the operation here, and the CBF ameliorated. So the interval between the anterior circulation surgery to the posterior circulation surgery is variable. When the patient was first operated, less than 10 years of age, the additional surgery is performed within 4 years. But when the patient was initially operated more than 10 years of age, this interval was very long, and two patients received additional surgery more than 10 years after the initial surgery at the juvenile age. So this is a girl who received the initial operation at the age of 12 and symptom ameliorated. But at the age of 24, TIA symptom recurred. At that time, PCA region, PCA disappeared. And CBF in the posterior circulation gets worse. And we applied the EDPS to the occipital and the posterior parietal area. So very good revascularization were induced and symptom disappeared. So application of DSC MRI technique enabled the CBF-based decision-making for juvenile Moyamoya disease patient. By this strategy, surgical treatments of Moyamoya disease were conducted on the selected area of brain of the selected patient. That means maybe individual surgery for patient. But the late onset worsening of vessel occlusion in the posterior part of the brain will matter to be followed up for surgical treated Moyamoya disease patient, and long-term follow-up will be necessary. Thank you for your attention.
Now we have Dr. Scott do the discussion, then we'll have the questions. You can stay local, please, after.
Well, I congratulate Dr. Nariai and his Tokyo colleagues for this work. It's very, very interesting, I think, and there's a lot of interesting data presented in this talk this morning. The purpose of their paper was to evaluate pediatric Moyamoya patients with these cerebral perfusion studies to determine what the appropriate surgical treatment of the patients was. And the major point of their paper was that cerebral perfusion studies can be used to tailor the location and the timing of the surgical procedures. And they had 111 patients where they attempted to do this. They contrasted these study patients with 165 patients that they had treated prior to 2001, just with the standardized EDAS procedure, regardless of the arteriographic findings or the data, the perfusion data, which I guess they didn't have then. The results compared with the pre-CBF measurement patients were fewer, and these are very interesting points, I think. Fewer patients overall were operated on when the hemodynamic tests were used as a part of the surgical criteria. It was 95% previously versus 80% now when you looked at the cerebral perfusion data, and you heard Dr. Nariai say we didn't operate on this patient even if the stenosis got worse because the perfusion data stayed the same. They did fewer bilateral procedures after these evaluations, 46% in the old days versus 35% now. And this is already, interestingly, a very low percentage of bilateral operations in any of the surgical series. Certainly in Boston, if we have bilateral disease, we tend to operate on both sides and get them done at the same time regardless. There were more operations initially directed to the posterior circulation, 6% in their prior group of patients, and now 7% getting directed operations to the posterior circulation. So I find these very interesting findings. To me, I noted that their perioperative infarct rate of 4.5% and their age at initial operation of almost 7 years was just about the same as our series in Boston. It makes me think that we're seeing probably the same types of patients. Surgery on the opposite side in both groups took place within 2 years of the first operation, but they don't say what's happened clinically to these patients during that 2-year waiting period. Many of the patients that I observed without operating on the second side initially had neurologic events forcing us into operations on the opposite side. Hence, our decision paradigm now to operate on both sides initially rather than waiting. Late worsening in the posterior circulation occurred in 2 patients, and they are now performing more prophylactic posterior circulation operations than they did previously. Well, as I mentioned, I congratulate the authors on attempting to put this revascularization surgery on a more scientific basis in this very large series of pediatric patients. It was interesting to me, though, to note that we rarely do prophylactic posterior circulation surgery. we commonly see posterior circulation vasculopathy on angiography and on the MRA studies on our patients, but it's very rarely symptomatic. And in our patient group, my own patient group, over 30 years, I've only done 4 posterior circulation revascularization procedures based on clinical criteria, although there's many indications based on arteriogram criteria. Despite where the revascularization procedure is carried out, that is, if you carry it out in the temporal or posterior frontal region, the collateral does appear to be directed to where the perfusion deficit exists. And I think time after time, those of us who do this surgery frequently observe this. The exception to this, in at least my own practice and in Ed Smith's, seemed to be in the anterior circulation, where leptomeningeal collateral pathways in some patients appear to be deficient and where additional surgeries may sometimes be required. This has been our most difficult area in Boston, the anterior circulation. Moyamoya is almost invariably progressive, and to watch a patient with severe involvement who still has good perfusion, I don't think is necessarily a good idea. And as I mentioned, the authors don't discuss any morbidity related to this expectant approach. And this is an example of a case, for example, where the collateral is redistributed to where it's needed. The angiogram on the left shows the preoperative angiogram on a patient where you see that large area that's underperfused in the frontal and anterior regions, and then after the synangiosis is done, the collateral seems to be directed to where it's needed, regardless of where the synangiosis is sited. I congratulate the authors again for this very interesting scientific piece of work looking at this data, and I think we'll be hearing more from them as time goes on. Thank you.
Thanks, Dr. Scott. Any questions for Dr. Nariai? Yes, please use the microphone if you can. Want to come back up?
Thank you for the paper. I have a question. When you do this MRI, you are using a resting state of cerebral perfusion. We don't know what will happen if these patients are subjected to some sort of a hemodynamic stress.
Like acetazolamide, you mean?
I'm sorry?
Acetazolamide, Diamox.
So do you use Diamox in your...
Yeah. I have a long experience of using Diamox challenge. I started this in 1990. But if we perform the Diamox study with a good CBF technique, it provides us suitable information. But the Diamox challenge test for juvenile patients is very difficult. Sometimes patients may experience the TIA at the time of examination. And follow-up using Diamox test is very difficult at outpatient base. So we changed our method from Diamox to DSC-MRI. So DSC-MRI is far more non-invasive, so it's appropriate for children, I think. But if you use challenge test, CBF challenge test, we can obtain a good information. That's true.
Any other questions? Can you comment on Dr. Scott's question about those 2 years, how symptomatic those patients were, and how you made that decision to go back 2 years later?
So it really depends on patient. After the operation, we performed the follow-up using DSC-MRI 3 months interval. So for some patients, we can find the progress before it becomes symptomatic. But sometimes, for some patients, we perform the follow-up study after a patient complains symptom.
Yes.
Along the same lines, as Dr. Scott mentioned, with all your cohort of patients who had bilateral disease and they had normal perfusion, have any of them got into trouble with strokes, irreversible neurologic deficit, because you didn't revascularize the patient prophylactically?
Fortunately, by now, I've never experienced the patient who experienced the stroke in the other side. All patients were operated during the TIA stage.
Thank you.